Worked okay? Okay. Prior to the presentation, I just wanted to review some housekeeping items, so please pay close attention as there are some key messages. The handouts for today's presentation were sent to you via email by our regional stroke education coordinators. You can also access the presentation on the West GTA Stroke Network website at www.westgtastroke.ca under the section Professionals, Educational Resources, and then Provincial Stroke Grounds. And I believe my colleague has posted the link in the chat as well. This virtual presentation will be recorded and archived on the West GTA Stroke Network website and can be accessed through the link that will be provided in the follow-up email you will receive in the coming weeks after today's presentation. Please check that your Zoom is on mute. All microphones should remain on mute during the presentation unless someone from your site is asking a question. The presentation is sound activated, so if your microphones are not muted and there's any noise in the room you're in, the video will switch to broadcast your site. Please ensure that your video is also off during this session, as it can create the system to lag and cause disruption. Should you be joining via the phone, please note to mute and unmute yourself, you press *6. Please remember that the views expressed today are those of the presenter and not the virtual Zoom platform being used. Reflective questions will be included throughout the presentation, and an interactive component will be held during the last 10 to 15 minutes, when we will have a question and answer period and hope to hear from as many sites as possible. However, throughout the presentation, if you could please type your questions into the chat section, that would be fantastic. We do ask that you please complete the evaluation. To do the evaluation, you may complete it online or fill out a paper copy that was attached in the email invite and send it to us. Please email or scan the paper evaluation to the email listed at the bottom of the page. Certificates of attendance were also attached in the email invite. Please fill in your name and keep for future reference. This is our mitigating bias slide by the Provincial Stroke Grounds Committee. So the Provincial Stroke Grounds Committee mitigated bias by ensuring there were no industry involvement in planning or education content. For-profit and not-for-profit affiliations have been disclosed by the speaker. Certificates of attendance were also attached in the email invite. Please fill in your name and keep for future reference. Okay, so next I'd just like to introduce our lovely speakers today. So we have Katrina. She is an occupational therapist and assistant professor in the School of Rehabilitation Sciences at the University of Ottawa. Through her research, Katrina Sauvé-Shank aims to understand the influence of social determinants in health on rehabilitation and participation. Patrick Duong is an occupational therapist and PhD candidate in the School of Rehabilitation Sciences at the University of Ottawa. He is involved in research on employment income and benefits and supports for stroke survivors. And with that, I'm going to hand it over to Katrina and Patrick.
Thank you. We'll just first do our disclosures. So myself, I'm chair of the Community and Long-Term Care Committee with the Champlain Regional Stroke Network, and I'm a member of that steering committee. So that's one of my affiliations that's pertinent here today. And I do receive some money from the Social Sciences and Humanities Research Council of Canada for a project that's not directly what we're presenting today, but it uses some of the results that we're talking about today.
As for myself, I have no relationships with for-profit or not-for-profit organizations, and this program has not been funded, or there's no financial support for this. Okay, so the objectives for this session are first, to explain some of the challenges related to return to work after stroke in Ontario, and secondly, to identify opportunities for supporting people who have experienced stroke, who are facing barriers with return to work, to access social services and community resources. To begin, I would like to talk briefly about why work is important. Well, work is an integral part of daily life. It's often necessary for financial reasons, to earn a living for yourself and your family. Beyond that, work is also important for other reasons. For some people recovering after stroke, returning to work can be a valid goal for them to be involved and to reintegrate in the community. Work is also an opportunity for social interactions, being at the workplace with team members and around other people. It allows for social contact and building relationships. And this leads to a sense of belonging. Working also has psychological benefits as well. In studies, people who return to work often report having greater self-esteem, feeling more independent, and having routines that give structure to their daily life. People who return to work generally report having higher life satisfaction compared to people who are not able to return to work. And on the other hand, these people generally report lower quality of life and are at greater risk for mental health problems such as depression and anxiety. So this is all to say that work can be very important, not just for making a living, but also for social contact and psychological well-being. So who returns to work after a stroke? This is a study we did fairly recently in 2020. The goal of this was to examine how many people intend to return to work after stroke in Ontario. For this study, we used data from the Canadian Institute for Health Information and the National Rehabilitation Reporting System. This is an ongoing initiative. It collects patient data, mostly administrative data, information about health services received, and also some data about daily functioning, like the functional independence measure scores, the FIM scores. So in this study, we were interested in people who had a stroke and received inpatient rehab across all of Ontario during the time period of 2012 to 2017. We looked at the discharge records and documented if people intended to return to work, for example, in paid employment, full-time work, or part-time work, after being discharged from rehab. So these were the main results here. So during this time period of 2012 to 2017, there were about 25,000 people who had a stroke, and they received inpatient rehab. Now, of these 25,000 people, about 4,600 were in paid employment before their stroke. So that's about 18.2%. And then of those people that were in paid employment, around 2,000 intended to return to work. So 43.7%, which is still quite a fairly high number. Now, if we take a closer look at some of the characteristics here, we see that there were no significant differences by gender. So there was about the same number of women and men who intend to return to work. In terms of age, there was a significantly higher proportion of people between the ages of 35 and 54 who intend to work. However, it was interesting to note that among the people who were working before their stroke, 36% of people over the age of 65 still intended to return to work. And I think that's quite a high proportion, over 1/3. It's surprising to see that it can be this high given the assumption that most people retire after 65. So this shows that there are still quite a few people of that age who want to or need to keep working. Now, if we look at the level of disability, we see that there's a higher proportion of people with mild disability, total FIM scores that were greater than 80, who intend to return to work. And this isn't too surprising since people who have less disability probably perceive that return to work will be more likely. But what was surprising is that 24.2%, so almost a quarter of people with moderate severe disability still intended to return to work. So this would be people who have total FIM scores of 80 or less, which is quite low. So that was the intention to return to work. But how many people actually return to work and when? This is a systematic review that looked into this. For this review, we included studies that reported return to work outcomes for people after stroke. Altogether, we found that the number of people who return to work ranges from 4% to 90%, which of course is, that's a very large range and overall not that informative. We saw that, the studies varied a lot from different countries, internationally, not just from Canada. There's different settings, different quality of care, characteristics of the sample. But one thing that varied considerably was the follow-up time. So some studies looked at return to work at 3 months or 6 months, whereas other studies looked at return to work at 1 year, 2 years, or even longer. So to get a better idea of when people return to work, to get better estimates, we did a meta-analysis. We pulled together similar studies by follow-up time, and these were the findings here. So at 6 months, we saw that about 53% of people returned to work. At 1 year, this is slightly higher at 55%. And then by 2 years, 67.4%. And these are pooled estimates. So it's for all age groups and for both men and women. But we see that, the difference isn't that much from 6 months to 1 year to 2 years. So this comes to show that, return to work is very much a gradual process. Many people still encounter difficulties with return to work. So what are some of these challenges? What do we know about return to work? Well, there are a number of factors that can influence. The first relates to the person's functioning, use of their arms, their hands, their coordination, walking, standing, the ability to drive. Communication is also important. People with aphasia often have a lot of difficulty with return to work. But sometimes the most significant barriers are not just the physical limitations, but rather the problems that are not as apparent, so more hidden disabilities, cognitive issues with memory, concentration, and especially chronic fatigue. These issues have a large psychological impact. It can result in personality changes, loss of motivation, feelings of frustration and stress. So these are all issues that can have a large impact on returning to work. We should also consider the job demands. What type of work does the person do? What kinds of tasks? Does it involve a lot of physical activity, manual labor? Is it cognitively demanding with planning and problem solving, communicating with other people, interactions? And ideally, the person needs to meet the job demands to return to work. But we know that's not always possible. In this case, perhaps accommodations can be made so that the job demands are more in line with the person's current level of function. So perhaps there's something that's less physically or cognitively demanding, so that they can still be productive and minimize that risk of fatigue and stress. Perhaps the workplace can also be modified so that it is more accessible for the person. And of course, whether this is possible, make accommodations and modify the workplace, it depends on the employer. Some work environments may be more flexible than others. One barrier to return to work that is commonly mentioned is that traveling to the workplace can be difficult. So just arranging to get to work is already challenging enough, especially if it involves driving or a long commute by public transportation or someone using a wheelchair or other mobility aids. Some other factors that can influence return to work include the social environment, such as the family and the financial situation. If the person is the sole income earner for the family, there may be a greater need to return to work quickly. Otherwise, if there's another family member, if the spouse is working and still able to earn sufficient income, then maybe there's less urgency to return to work. Support from employers and coworkers can also have an impact. I think it goes without saying that people who do not get along well with their employer often find it more challenging. They may be pressured to return to work when they don't feel ready yet. The employer doesn't understand why they aren't able to work yet and why it's taken so long. Well, the person still needs more time to recover. They're not getting the support they need, and it can get confrontational. On the other hand, people who have a good relation with their employer and coworkers are more successful in returning to work. Just receiving encouragement and positive feedback from colleagues is definitely an enabler for that. And then lastly, people who have more stable jobs, access to disability insurance, find that gradually returning to work is more manageable and less stressful. But it can still be challenging to learn about the employment policies and disability benefits. It can also be difficult to know, what local services might be available and where to go for help when you have legal questions about return to work. So what can we do to help? As providers, how can we support return to work? There are some recommendations by the Canadian Stroke Best Practices in this section on transition and community participation following stroke. 2019 was the latest update. So it's recommended that people with stroke, their families, and caregivers should be provided with information, education, training, support, and access to services. And this is to help with returning to life roles, in this case, vocational roles such as work, school, volunteering. So I'm just going to highlight some key points here. After a stroke, people may be assessed if they're interested in returning to work. And if possible, this should happen earlier on in the phase of rehab so that goals and a plan can be established. Return to work can be a gradual process. And referral to other services, so counseling, vocational rehab may be considered as well. And if needed, referral for a more detailed cognitive or neurological evaluation. So that was a very brief overview. In the next slide here, I will discuss some more suggestions of how providers can help support return to work and give a few more examples. So starting off with assessing, ask if a person intends to return to work. I mean, is it a priority? And if so, what are their goals specifically? When do they hope to return to work? In what capacity? Full-time, part-time, same job, different job? But some people may be more eager to return to work as soon as possible, whereas others may be unsure if it will be possible at all. People who had a mild stroke could return to work very quickly within weeks, while others may take months or years. So it largely depends on their recovery, their level of function, their job, workplace, supports. It's not necessary to discuss everything all at once, but just getting the conversation going and talking about realistic expectations early on would be best. So talk about what do they need to do at work. Describe their job. And what are they capable of doing now? What concerns do they have? So I would suggest starting off with smaller attainable goals. Focus on the positive. What can the person do at the moment? And in the beginning, it may not be feasible to return to work full time. For example, 8 hours a day, 5 days a week, assuming that's what their normal work was like before. But instead, a more realistic short-term goal might be, would it be possible to work just 2 to 3 hours a day or 3 days a week? And if things go well, increase it from there. It may seem obvious, but it's so important to reassure the person that return to work can take time and to not rush in and become overwhelmed and then have to take time off work again. So doing it slowly day by day helps to build the tolerance to work, and confidence in their capacity to work. That yes, it is possible to overcome these barriers and return to work. Now, collaboration is key. So encourage the person to discuss their plans for return to work with their employer, their health team, and with other people involved. For example, this may be like an insurance provider, a case manager, a union rep, or employment services. It's important to remind the person that it's their right and responsibility to share information, and try as much as possible to stay in contact because it will help avoid miscommunication and disagreements that may arise down the road. But employees have a right to have work accommodations in accordance with their workplace policies, and they should be informed of these policies. Supervisors also have a responsibility to protect the health and safety of their employees and provide necessary accommodations. So again, encourage the person to plan with their employer, be clear in communicating what their needs are, and they should explore the options together. And then providers can also give in their input on what accommodations would be reasonable. So some examples might be, adjust your schedule, fewer hours, fewer work days each week, modify the task, use different equipment. Is it possible to have more time to do a task? Is it possible to have more breaks or longer breaks? Or is it possible to get additional help from your coworkers? Referral to other services can also help with return to work, depending on their needs. So occupational therapy, physical therapy, speech, social work, and certainly vocational rehab. And then if more in-depth cognitive testing is needed, then perhaps also a neuropsychological assessment. People who experience mental health issues may benefit from counseling, and connecting with peer support groups can also be inspiring as a way to learn from others and share experiences. So since return to work can take time, it's a good idea to follow up on the person's progress. Checking in to see, have they been improving? How do they feel? Are they ready to do more? And are the accommodations working out so far? And if so, can the job demands be adjusted and perhaps gradually increased? Now, if it's not possible for the person to perform their work tasks, even after trying different accommodations, then looking into alternative employment may be an option. It could be a different position in the same field of work, or it could be an entirely different job somewhere else. But this is usually considered as a last resort since it requires a larger investment of time and retraining on a new job. Another option could be volunteer work as well, which is still a way to keep occupied, develop skills, and feel productive. So the next few slides are just a few resources to show some examples of some websites with some useful information, guides, and handouts. And then on the last slide of this presentation, you will see a full list of this as well. So for example, here, we have links for employment services around the Champlain area. These resources are usually specific for a particular region. If you click on employment assistance here, you'll get a large listing of services around that area, and you'll see their address and their contact information. So to find the site like this for your particular your region, what you can do is you can do a quick Google search, and here I'll type it in right now. So you want to search for Healthline stroke resources employment. And what you do here is you replace the region here with your particular area. So for example, here I did Champlain, but you could also have, for example, Toronto Central or Central East. So if you do a Google search like this, it'll usually be the first or the second the link that comes up. And you'll find here resources for return to work, volunteering, but then there also may be some links to external websites where there are some other tools or guides that have been created to also help with return to work. So another place you can look for resources is the regional stroke networks in Ontario. Some of the links may already be found on the previous Healthline website, but if they're not there, then it might be worth checking out here to see if there's still more information. This, for example, is the Stroke Network of Southeastern Ontario, and they have a large listing of links as well. This is March of Dimes Canada. It's an organization aimed at helping people with disabilities. They have employment services programs to assist with return to work in general, not necessarily specific to just people with stroke. But then they also have a after stroke program to help with recovery and connecting with community resources. Here, this is a guide prepared by the Southwestern Ontario Stroke Network. This is a self-assessment guide for people who have had a stroke and are thinking about return to work. So essentially, the person here is asked to evaluate their own abilities, things like their physical ability, communication, thinking. And then they're also asked to evaluate their job demands. And they score this on a 1 to 10, out of 0 to 10. And so the idea is to see how well do your current abilities match up to what is expected for your job. Something to keep in mind is that it's a bit of a lengthy assessment here, and the person does need to have a good self-awareness of their own abilities in relation to what is expected for their work. So it might be beneficial to have help from a professional in going through this and getting the feedback. But it does cover a lot of important areas, and it is a way to bring up the topic of return to work for discussion. Here we have a readiness checklist by the Heart and Stroke. Um, it's similar to what we just saw previously. It asks the person to rate their own abilities and then to think about the job demands. But it doesn't go into as much depth. It's much shorter and only about 2 pages, so it should be a lot quicker. This is a quick guide by the Toronto Stroke Network. This is again to help with planning for return to work. There are questions about readiness, the impact of stroke, the workplace, and accommodations that may be needed. And it also discusses how other providers may be involved in the process. The involvement of like a social worker, an occupational therapist, vocational rehab. Now, the last thing here is this is a toolkit that's being prepared by the Central East Stroke Network and the West GTA Stroke Network. This is a document that is going to be coming out soon. It's currently in work in progress, but should be out sometime next month in June. There will be a lot of useful information here for providers. So not just for people in healthcare, but all across the care continuum. Things on like local resources and employment services, financial support, mental health support, volunteering, return to school, and transportation. So there's a lot of good information here. And what we often see is that, we see information scattered across a lot of different websites and other sources. So it's nice to see a document like this being made, bringing it all together so it's easier to go through. So for sure, if you're interested in learning more, definitely keep an eye out for when this becomes available. So with that in mind, the next slide, I want to discuss briefly some of the gaps in knowledge and areas for future research. The first point is that we understand that return to work can be complicated. It's difficult enough for people after stroke to find and get the support they need. And as providers, it can also be difficult to know, what can we do to help support them? There doesn't seem to be a formal process, that guides providers on what should be done and when. While there are recommendations by the Canadian Stroke Best Practice, those recommendations are still kind of general. There might be some institutions or care teams that have their own process for assisting with return to work, but in most places, I don't think this is something that has been clearly established. Return to work it's usually not a high priority, especially in the hospital setting, and perhaps it's something that may only be addressed in rehab if there's enough time, or otherwise, after discharge in the community. In addition, return to work it's a topic that many providers don't feel they are too familiar with, or that it may not be within their scope of practice. So moving forward, if there were more educational opportunities, providers could be better informed about return to work. And this would also encourage more discussion among team members, which could help with bridging this knowledge gap. Another issue that can be that could have an impact here in terms of gaps of knowledge is that it's difficult to measure return to work outcomes. We don't have much data about it in Ontario. I'm not sure about other provinces, but it's probably not likely either. But return to work is not a metric that is captured. So, just going back to the first study I mentioned earlier on the intention to return to work, that study used data from the Canadian Institute for Health Information at discharge. And this is data that is mandatory to be collected. It's mandated. And, we saw that across Ontario, there are still quite a few people who intend to return to work after discharge. But we don't know if those people actually did eventually return to work. So, while we do collect data on follow-up at around 6 months, this is only about 1% of the time or even less because it's optional. So, this follow-up data is not the most reliable. And that's why it's so difficult to measure and see if people are actually returning to work. The last point I wanted to mention here is that there is inconclusive evidence on the best interventions. In the literature, we see that there are a fair number of intervention studies for return to work after stroke, but most reviews have found that the quality of these studies is not great. There are very few RCTs, and most studies are like cohort studies or intervention studies that don't have a control group. And we see a lot of mixed findings, and it's just not clear what exactly are the interventions that are most effective. But the best approach seems to incorporate a combination of an individualized plan that depends on the person's situation and their job, the involvement of a multidisciplinary team, and a combination of providing cognitive and social support strategies. So counseling on like coping, motivation, adapting the work environment, and tasks to accommodate the person. So all in all, it remains an area where higher quality research is needed. I would like to take a minute now to pause and to think about, as a self-reflective question, in your region, in your area of work, what is being done along the continuum of care to support those who want to return to work? So this is something you can think about, and then we'll resume in about 1 minute.
So that was about 45 seconds of thinking that we gave you. Hopefully you can continue the conversation after the presentation today about the continuum of care and work. So there are many situations. So Patrick's talking about people returning to work, but there's many situations where people may not return to work, so it's the short, the long term, or maybe even ever. And when somebody's not able to go back to their job, a possible important consequence is a change in their income. And often it's a reduction in the income. And there was a study that was done in Canada in 2019 that found that people who had a stroke had on an average income, so their average total income was lower than the average total income of people who did not have a stroke. And that was with a group that they compared that had the similar age, similar gender, and from a similar region. So thinking about changes of income, it's important to consider that it will not have the same impact on all the different people. So if you asked your patient, what happens if you don't go back to work on Monday, you'll have many different answers, and there are many, many different realities for each person. So perhaps the person did have a very good income and a very good salary at the time of their stroke, a very stable job, and they had access to insurance and maybe some benefits. But maybe a person was already in a job where their income was very low and that they were always sort of teetering to have some financial difficulties. Maybe they didn't have access to insurance and benefits, and there's not everybody who's eligible to get employment insurance either. So thinking about these things, what type of work did the person have? Was it contractual work? Was it seasonal work? Was it maybe all types of smaller part-time positions melded together? And Patrick did mention it. Was the person supporting others with their income? And again, not looking specifically just at age when we ask these questions about Monday going back to work. We should be considering the people over 65 to see if what's their intention as well. So while some people may be living with financial difficulties prior to the stroke, some will fall into the lower income bracket after the stroke. And regardless of when or at which point that happens, living in a low income situation can have, or having financial barriers can have a lot of challenges for a person. So some challenges that can happen are difficulties accessing healthy foods, affording your medication, being able to obtain the safety equipment. So your walker, bathtub transfer bench, being able to pay your rent, being able to pay your mortgage, that might be very much affected, and also being able to return to your everyday activities. And here we're talking about being able to afford housekeeping or extra personal support workers, but also being able to pay for a new pair of running shoes because the physiotherapist or your doctor informed you that maybe you should do some more exercise. So money influences the health, the well-being, and all of the opportunities to participate in life after a stroke. So thinking about this, many people will need to be connected to different types of services and resources. So assistance to pay for that medication or to pay for that the equipment that you're going to need. So what is our role as healthcare providers or service providers after stroke? So again, we're going to look at the Canadian stroke best practices. And again, this is the update of 2019. You'll notice that we've shortened the sections. They're not all in there on this slide. So you can go and reference the original if you'd like to see everything else that's written in between. But the best practice guidelines tell us that we should be discussing finances and benefits as it relates to work with all the people that we encounter. And we should be helping people who've had a stroke and their families or care partners to apply for the different types of disability support services. And we need to help them navigate the system because it is very complicated. All of this should be done in a timely way as best as we can so that we can avoid delays for the person when they apply to different services, because there's long processing times often. There's multiple step applications and there are a lot of wait lists. And this may not be new information to you. You may have already tried to apply for different services for your clients or your patients and found that that is a reality. So the big question is, are we currently doing enough to connect people to the needed services and resources? Now, there's been several research, lots of research, lots of studies done internationally in Canada, and a lot of them in Ontario as well. And the researchers have looked at this question from many different points of view. And referenced at the bottom is the one study that we did that looked at the point of view of a person who's had a stroke, who was in a low-income situation. But there's other recent publications that have simply come out. So one of them was from 2022 from Anna Garnett and her colleagues out of Southern Ontario. So it's not referenced here, but if you'd like the reference, I can send it to you. And they looked at the point of view of caregivers or families. So of all the research that really is out there, the main message is that it doesn't look like we're doing enough to address people's needs when it comes to connecting them with the social services and community resources, in particular to address their financial concerns when there's been a change in their income. So for us, we thought, well, what's going on? Can we better understand this? So we looked at the experiences and the points of view of some healthcare professionals in one region and some stroke teams along the continuum of care. So from acute care all the way to outpatient. And this is a study that we're currently finishing up, so not yet published. And what we did is we asked healthcare professionals along the continuum of care, what are your usual healthcare practices? What do you do to connect people who have an immediate income need or who might develop a problem in terms of their finances? How do you help them to connect to services and resources? And how do you address the whole question? So when we look at our preliminary findings, what we found is that usually only immediate needs that will affect the discharge are addressed. So for example, directing somebody to find discount or secondhand equipment so that they can be discharged home with fewer safety concerns, or helping a person apply to EI, so employment insurance, if the person was eligible. And oftentimes people are assisted to find services that may help them to pay for their prescriptions. What we also found was that teams rarely consider the less immediate income concerns, especially those that are related to return to work. And in looking at the reasons behind this, there's multiple reasons, but the main ones for why the healthcare professionals have not been able to address anything outside of the immediate needs really has to do with competing priorities. And this may be a reality for you as well, listening today. So this competing priorities, no time, fewer resources than you'd like to have, and you have a lot of things to address every day. There's also a lack of knowledge about what's available and how to access it efficiently. And also there's assumptions about who along the continuum of care is actually responsible for these questions. So people in acute care thinking, maybe this will be taken care of in inpatient, and the people in inpatient thinking, maybe this will be taken care of in outpatient, and the people in outpatient thinking, maybe this will be taken care of in the community. So overall, it's not consistently addressed. So what should we do? How can we best support people to access the social services and the resources? So again, there's a lot of research that's been done internationally, in Canada, in Ontario on this topic, and there's many innovative approaches. There's lots of pilot programs, many different actions being trialed or already set up maybe in your regions. But what works best? So to try to answer this question, so this is another systematic review where we put information together. So we compare all kinds of interventions that have the same goal. And the goal that we were looking at is, how can we help people connect and access services and resources after stroke? So we put all of these studies together. We look at the results, how they did their interventions. And I guess we could say, unfortunately, we did not find a clear clinical practice recommendation. So that means that when we look at all the studies together, it's difficult for us to say, do this and it will work. And the main reasons that we can't find clarity is that a lot of the interventions are too different to compare. So they're using different measures, for example, to measure success, or they're done at not exactly the same time in an admission of a person who's had a stroke. But I think it's noteworthy. So I think it's worth mentioning that one size fits all solutions won't work regardless. Okay, so that any good idea or any intervention that somebody does in one place, you need to adapt it to your local reality and your local context. So from looking at all these studies, we did learn quite a bit. And what we did learn was that you need to discuss financial concerns early on in the admission and to continue along the entire community continuum of care. So all the way into the community when people have left the organizations where maybe you might be working, and maybe you are working in the community, you need to address it all the way through, and it's never too early to talk about it. Also, tailoring information to a person's needs. This is something we often talk about for all kinds of education that is given to people, no matter if it's a person has had a stroke or some other illness. If you give information that is too general, it will not be useful. And specifically, something that we found in this review was that it's difficult for people and their families to know what they might need on discharge or what they might need in a few months after their stroke. So it's important not to rely too heavily on these types of questions to guide your intervention. So asking a person, what do you think you might need, is only part of the story. As service providers and healthcare providers, we need to start imagining for the person what they might need and start to supplement. So what do we do in a practical sense? So from the current study that we were talking about the healthcare professionals, these participants had some ideas about ways to better support access. And we invite you to consider these suggestions as well. So the first one, and I'll ask Patrick to, there we go. I don't have the clicker button. The clicker button is in Patrick's office. So we've been doing well so far. So the first suggestion is to consider return to work and income as a team. So it's not just the social worker's role, it's everybody's role, perhaps. Maybe we can all take a part of that new responsibility. We need to ask about return to work and the services and resources as early as possible. I think we're really underlining that recommendation today. So you can always ask at any time, and anybody can ask the person, how do you think you'll be in terms of your finances if return to work is delayed? If you don't go back to work on Monday, how will that be for you and your family? And again, understanding that they may be in that situation for the first time, so we need to guide their thinking as well. We need to create lists, or perhaps you'd like to create some lists of resources that can be easily personalized. Learning about the system and its limitations is very important. And also clearly communicating, if you find out something about the income of a person or their employment, it's important to send it to the next people down the line so that they can carry on from where you left off. Now, we'd like to invite you for one last little think. And this time it's about what is actually being done on the continuum of care to support people who might not or cannot return to work. So some of you may be alone where you're watching. So maybe have a think, and if you have a bigger group, you can have a discussion of what is actually being done along the continuum of care. And we'll give you another 30 or 45 seconds to think about that, and then we'll come back for conclusion. So I hope that was enough time to have a little bit of a think or a little bit of a chat. And I apologize. I looked at my watch to see how many seconds I was giving you, and then I forgot what time that was when I started. So we'll just conclude and then maybe have a chance to ask your questions. So return to work isn't important, but it's a complex goal to address, and especially in our system as it is currently set up. And we talked about all of the challenges along this presentation today. And it's important that we remember that while it may not always be an issue for a person who's had a stroke, it's important to remember that for some, the change in income related to their inability to immediately return to work or later may have a significant impact on their life. So considering how complex and challenging it may be to add return to work and all the connections with the social services and community resources to the responsibilities of your team, I think that our main message is that remember that any action you take to connect someone to a service or a resource will have an important impact on their life. So anything you do will help. So we have a list of references, and we'll go through them very quickly. And we have the resources that we've attached here. And the last part is questions. So we invite you to, you can use the chat, and I'll be monitoring the questions on the chat. If we do not have time to address all of them today, please send them to Maggie. Her email address is at the bottom, and she will forward them to us for answering. So thank you for listening.
Thank you so much, Katrina and Patrick, for such a comprehensive and informative presentation, especially on this hot topic, return to work. I just wanted to highlight that we had, it was very well attended, a provincial stroke round. Some people will start to fall off now if they don't have any questions at this moment, but I do encourage people to do the evaluation. I'll bring that up after. So again, just to reiterate what Katrina has mentioned, please, I see there's some things going through the chat box here, but we also have Maggie Treado, our community long-term care coordinator with the West GTA Stroke Network. She can also take some of the questions we don't get and send them out after the fact. So if you want to go ahead and take some questions, and then at about like maybe 3 minutes too, we'll see how many we can get through, or and we'll go from there. Okay.
All right, so I'll just ask Patrick if you can put the resource slide back up, please. That was a request from someone in the chat. Thank you. Maybe what I'll do is that I'll read, there's a comment from Jennifer, and maybe I'll read it out loud. So Jennifer says it's extremely complicated and difficult to support patients with return to work and is highly dependent on the type of work and benefits the patient has. Provincial programs like ODSP is extremely narrow in its definition of disability, and often patient applications are declined. In my experience, certain employers are all or nothing in terms of return to work, and it is not feasible to accommodate patients with return to work. In the acute setting, besides giving the patient a doctor's note, filling out insurance forms, and discussing financial concerns, there's too much going for the patient to really address this. So that was a comment from Jennifer. I'm not sure what region you're from, Jennifer, but.
Hi, this is Jennifer Manzi. I'm from the Southwest region. So I'm a stroke neurologist. Yeah, so it's I struggle with this every day, and I appreciate your presentation, but I think when you're faced with patients in front of you, what's very difficult is you know what a patient has in terms of disability, but it's hard to translate that into if they can go back to work. Sometimes it's very obvious that they cannot go back to work, and sometimes it's not. And a lot of physicians, we're not occupational physicians, right? And we don't really have those supports. So, often we work with the team, and the team will say, well, discuss with your physician. So, I mean, that's one thing that I find quite challenging. So, and that's for me, sort of an area where I don't feel particularly supported. Besides, I want to help my patients go back to work, but sometimes you don't really know until they try to go back to work. And when they try to go back to work, they're not successful, or they can't be accommodated. So, Yeah. So I appreciate all the resources, but from a practical point of view, when you're trying to work with a patient and their specific job, that's where I feel there's a gap.
Yeah, Patrick, did you want to make a comment on that or?
No, I think, a lot of those points resonate with, some of the concerns of why, it's so difficult to address return to work. Actually, I guess I had one follow-up question, and that is, for you, if you had the ability to get some more help for you, do you want to know more? Do you want to have more resources? Do you want to have more time? Like for you,
Well,
what would be the number one thing if you had to pick?
Well, I think
Your
the
life easier?
resources, like I use some of these resources, right? So,
Mhm.
I try to support. It's often a lot of this is often left to the physician. The team helps support the process, but
Right.
filling out forms, insurance forms, it's painful. I hate to say it, but it's not. And some of the things, as I said, it's like, oh, can this person carry 100 pounds? Like, I don't know. Like, it's not something that it's a gap in our physician training, right? That we're not really taught about some of these things as well.
Mhm.
And I've just sort of learned about it as I've had to support patients. So, I have all the resources, but I think when it comes down to it, and you did highlight this, that it's a very individual, each job is different, right?
Mhm.
So I don't know how you would support that, right? In terms of that. So maybe vocational, like physicians, but I don't think there is a lot of occupational physicians that are out there. So um, we're pretty well resourced in the Southwest, right? So I work closely with OT, PT, social work. We often don't have one of the issues is unless they're in a program like a community stroke rehab program, in that we don't have social work support. And as you know, those programs are limited in terms of the duration of programs. So then you're kind of helping navigate all these issues because there isn't someone you can fall back to. Because return to work is often, for some patients, it's not within the first 3 months. It could be 6 months. It could be that. So I think the vocational, yeah, sort of resources and how you translate what a patient's deficits are and their job, that's where the gap is, like how to
I
figure out
can,
if they can go back to work, right?
yeah, maybe I'll jump in, Jennifer. I see there's a lot of people who agree with you on the chats about the challenges, and I think one of the things that I'm not sure how much we highlighted in our presentation, but it is not in our system as it's set up right now. There's no actual place where it is formally, here is your job, you do return to work. It's a little bit like this, right? Along everybody tries to do a little bit. So that is one of the big challenges, is that it's not formally, for example, self-care is formally included in one of the tasks of rehabilitation, and it's captured as a metric, as Patrick was saying. So return to work is not right now. So whose job is it and who should be doing it? It is a challenge. And as you mentioned, the time between when you can't work and you maybe return to work, there's a lot of personal challenge people are having. And you're talking about ODSP, that's so an Ontario Disability Program for those who cannot return to work. That is a challenging application form itself with all the eligibility things as well. So I'm just going to quickly look. Did you, thank you, Jennifer. And there is vocational rehabilitation services in some places, but it's not necessarily for people with stroke in all regions. So I think Patrick, the resources you gave. So I'm going to look down here quickly. So somebody asked, how do you access neuropsych evaluations? It's often too expensive for people to pay for themselves. I think you answered your question. Often it's only in the realm of private services. The supporting documents can be found at the, sorry, that's, what is the law about the amount of accommodations that an employer can provide? And then I see below that, Shelley answered, typically the employer is required to accommodate to the point of undue hardship, which is pretty vague. Patrick, did you want to say anything about that, or?
Yeah, I would just make the same comment as Shelly did, that it is very vague. And, like the law says that, employers need to be informed of special needs, and they should make like their best to accommodate that without, going beyond what's like, considered reasonable. But, that in itself is a very vague sort of nation for that.
Becky talks about the difficulties with returning to work. Paula Jane says, you talk about multidisciplinary team, which I agree with, but when the person lives in the community, there's no access to a team. And some rural areas will have fewer and fewer teams to work with. As a social worker in an aphasia program, I assist as best I can, often by connecting people with employment services. Not my role to do vocational evaluations. Another person, Craig, says such a complicated issue with multiple layers or numerous layers. Paula Jane, I used to work as a vocational rehab counselor with the MCSS and could coordinate and engage all these different services and oversee the whole return to work process. But that program was disbanded and I don't think has been replaced. And Jennifer adds, neuropsychological services are available at regional hospitals. Some are covered by OHIP. Yes,
yep. So they are covered there. I mean, I bet some hospitals, it's often these programs are being disbanded, but if you need they are covered by OHIP. So if you have a regional center, I mean, in Toronto, I don't know what the services are. There's lots of services more than other places. But for instance, if you're in Sarnia and you have a patient who's had a stroke and you need neuropsychological testing that's covered, you can just refer them to our hospital. So you don't have to pay. The patient doesn't have to pay.
There's a comment here. We will be considering vocational support as part of Provincial Community Rehabilitation Project. That's Margot. I'm not sure, Margot, if that was a question or more of a general comment of what you do in your region.
Yeah, no, it's actually a provincial initiative that's being undertaken right now. We're looking at defining, blue sky community rehabilitation across the province and making it consistent. And so as part of the very early part is in defining like what community rehabilitation services will look like, across the whole province. And one of those is the definition. And we have been including questions in our surveys around vocations and return to work.
Excellent. Excellent. Now I see I only have 30 seconds, eh?
Yeah. I was just going to say thank you so much for there's so much discussion. It's such a fantastic topic and one that there's obviously a need for resources and more discussion. So I think this is a great Provincial Stroke Rounds topic. And again, as promised, my colleague Maggie Traido has copied and pasted all the questions into a Word document, and she certainly will be getting back to folks. So thank you again to our speakers and for the fulsome discussion at the end, for the participants for hanging on at the end and coming so early to Provincial Stroke Rounds. We certainly appreciate. So I'm going to get Patrick to put up the evaluation slide for me. So please, I encourage everyone to complete the evaluation, forward the completed evaluation forms to the contact listed at the bottom of the form, or you can scan the QR code. It just takes a couple of minutes to fill out, and certainly we use these to learn and drive our education forward with Provincial Stroke Rounds. In saying that, our next Provincial Stroke Rounds will be held on July 6th. And the topic is yield and feasibility of non-ECG gated cardiac CTA and hyperacute stroke. And that will be presented by Dr. Shirin Jalani and hosted by the Southeastern Stroke Network. And more details regarding these rounds will be coming in the next couple of weeks. As well, I just wanted to mention, you will see most likely in your emails as well, not only the follow-ups to these questions that were in the chat from Maggie, but also I will be sending around in the next couple of weeks just a follow-up email to summarize. And again, I will have that link to the West GTA Stroke Network website under the Professionals tab, where you can access the handouts and other information regarding today's presentation. Hopefully the recording will have worked and we will have that posted on our website as well. So thank you so much, everyone, for attending. And again, thank you to our presenters for your time and expertise on this great topic.
Thank you.